Thank you, Cecilia, Mr. Chairman, dear friends. Actually, as Cecilia told us, we are really facing with a new era which promises to be really amazing. I guess I have to push here, play. I don't know. Let's see if it works. We are in a digital era, so it should work. I will start with a short introduction to go soon after deeply inside the feature of this new incredible algorithm that is ArtLogic. Actually, we are all aware that implantable cardiac devices play now a fundamental role for treatment of heart failure. And actually, we know that ICD, like the last guidelines clearly state, can prevent sudden cardiac death, and also that CRT was very important for reducing symptoms and morbidity and mortality in heart failure patients. Furthermore, a few days ago in San Francisco, during one of the late-breaking clinical sessions in the HRS Congress, Dr. Kutifa presented the results of the MEGAMADIT trial. And so we had also an additional evidence of the beneficial effect of CRT. Because MEGAMADIT trial is a trial aggregating data coming from all the MADIT studies, and she clearly showed how over time we faced with a significant decline in arrhythmia burden and in death. And very likely this main effect was driven by the CRT action. But implantable devices are not important only for treatment of heart failure. We have learned that they can help us very much also for diagnosis of heart failure. In the last decade, all the company invested a lot of resources for developing new features, new algorithms able to monitor heart failure status of our patient, especially focusing on the detecting of an acute decompensation event. For instance, you know all the studies about the thoracic impedance monitoring. And everything was with the support of a remote management platform. But unfortunately, both the results of the study focusing on thorax impedance, like SAINT-HF or DOT-HF, were disappointing. They had disappointing results in terms of predictive ability of this algorithm alone, as well as the big trial assessing the impact of a fully remote management strategy had a negative or neutral clinical outcome compared to a standard of care management. But maybe we can explain why of these negative or neutral results, because we learn the lesson, and again, guidelines clearly state that we should focus, we should pay attention not only to a single sensor, not only to a single parameter, but we should perform a multi-parameter observation through the implantable device of our patients. And actually, this is also what we do in our daily clinical practice. When we have our patient in front of us, we evaluate him performing a multifactorial approach, because we ask him if he feels tired, if he gained weight, if with how many pillows he's sleeping at night. We measure the blood pressure, we visit the patient and listen to heart sounds and lung sounds. We perform a multi-parameter evaluation. Now, all these questions, all these complex assessment can be made automatically on a daily basis by the implanted device. That's the meaning, the core of the ArtLogic, because it's able to incorporate multiple sensors in a single composite alert. And this algorithm has been validated and created actually in a trial which was the MultiSense trial, which is an international, multi-center, not randomized study, which collected a chronic ambulatory data simultaneously coming from multiple sensors in implantable device, with the aim to develop an algorithm which could be able to provide an early detection of worsening heart failure. The main sensor involved were the heart sounds, the presence of STRI, the decrease of S1, thoracic impedance, of course, night heart rate, and respiration in terms of rapid breathing and reduced tidal volume, activity response, and so on, with the goal to create a very high-performing composite indicator of a worsening heart failure status. The study enrolled almost 1,000 patients. There were a development group which was used to develop the composite index and the alert algorithm, and a test group which was sequestered and used for an independent validation of the alert algorithm performance. The results were very, very encouraging because the study validated a very high performance of the algorithm with 70% of sensitivity in detecting pre-symptomatic indication of acute HF decompensation, giving us an anticipation of the clinical event on average of 34 days, with a very important amount of time. And another important issue, in my opinion, is the very low rate of unexplained event, which was as low as 1.47%. But actually, ArtLogic showed in the further sub-analysis also to be very able to provide a very important stratification function, risk stratification. We can see in this sub-analysis from Gardner that when we set the threshold at 16 and the patient are in the in-alert condition, that means that they are over this threshold, they have a 10 times higher risk of a clinical event, which is also, they are big numbers. And also we can see that only 17% of patient days are in alert status. So everything is telling us that we could pay more attention only to higher risk patients driven by the stratification provided by ArtLogic. And again, in the Gardner and the sub-analysis, authors also correlated the ArtLogic performance with the gold standard, which is the NT-proBNP evaluation. And they show that the ArtLogic performed really well, maybe even better than NT-proBNP, which was, of course, evaluated in the multi-sense trial only at baseline. Then we will see that in the follow-up analysis, we have also the availability of proBNP data at every hospitalization. There is a poster about that presented in this Congress. But anyway, going back to the sub-analysis of Gardner, we can see that when patients have a low NT-proBNP in the 002 column on the right, and they have a very, of course, and compared to when they are still in alert condition, they have not such a low rate event. While on the other side, when they are out of alert, also if they have a high NT-proBNP, they have a very low event rate. So this looks like that ArtLogic can perform better than NT-proB with a negative predictive value. And of course, when they both are high proBNP and high ArtLogic alert, we have 50 of event rate ratio, which is the higher. And another point is that half of the patients are in the lowest risk group. So another strong message. We can maybe start to pay attention only to high-risk patients. This means that we can prioritize our resource only for patients that really need them. We have experienced now since 1 year and maybe 6 months with ArtLogic. We have been one of the early adopters in Europe of this algorithm, and we were very lucky because we had the chance to perform 2 different kinds of analysis. Because we had the chance to analyze retrospectively patients that, when we enabled the algorithm, had already been implanted by an implantable device. So we could, in a perfect blinded pattern manner, go back to see the correlation between all the recordings, all the findings of ArtLogic, to see the correlation with alert, with the true, real clinical events that the patient had experienced. Moreover, then we also move forward, and now we have also the first preliminary data about the active phase. That means patients that have been implanted and soon put under monitoring by ArtLogic. Actually, the first retrospective phase resulted in a publication in this paper, which is summarizing all our clinical case report series about this, the use of this algorithm in our clinical practice. We collect data from 58 patients with an average follow-up of 5 months. We had 24 alerts with a 0.99 alerts patient year rate in 16 patients. And the algorithm showed to have a 100% sensitivity. So real life went even better than the trial results, with no one undetected heart failure event. Another important issue, we also improved the rate of unexplained events, which is even lower than the multi-sense result, 0.41 patient year, with a positive predictive value of 58. And about the data of the active phase, so the one that are summarized and presented in a poster here in Heart Failure in Athens 2019, we had data of 101 patients with a follow-up of 6 months on average. Again, we have 44 HL alerts with the similar rate of alert patient year rate, which is 0.95. And the majority of these events, almost 60%, were judged clinically meaningful. And even more important, in my opinion, is that no clinically meaningful condition or event were detected when the patient were in out-of-alert condition. So again, this algorithm really shows that it's able to perform extremely well to stratify our patient. And this is what we deal when we speak about our logic. This is the report we receive from the Latitude platform. We can have, of course, when present heart logic alert notification on the top, and then we have the heart logic composite index, which is a simple, clear number telling us that the heart logic index went over and crossed the threshold. We can visualize, of course, the threshold which is programmable, and then we can go deeply inside to see which were the main contributing trends to develop the alert. We can also see the detailed trend of every single sensors. And the real challenge, of course, once we have this wonderful tool in our hands, is how to organize, to manage it. Actually, there are no clear rules. The only polar star we could follow are the guidelines, and especially the HRS expert consensus statement about remote monitoring, which tell us that we should perform scheduled remote interrogation program with in-person evaluation when an alert should be present. But the truth is that in the real life, there is a huge amount of variety in terms of frequency of the checks, the kind of reaction that different centers put in action when they have an alert, which is different according to different kind of clinical alerts. So it's really still a wild world where there are no written and clear rules. So when we started with our pilot experience, we could only follow at the beginning in an empiric manner the suggestion coming from the company, which were focusing on pay attention on 3 different steps: the receiving the alert, the management of the alert, secondary, the assessment of the clinical status of the patient which was under an alert, and finally, which kind of action to have for responding to an alert. Our program of follow-up was the one that you can see here. We had a frequency of scheduled in-office visit that was 2 per year, remote data review that was once every month, and a daily check of heart logic alerts, and a check of re-alerts that was 1 every week. And following the flowchart that you can see on the right, there was the in-time model to easily talk about. That means that in the center, the personal dedicated review the alert, the report from Latitude, and in case of alert, there was the need to go to see which kind of sensor was contributing to the alert. Then there was a telephone contact with the patient, trying to verify if he was showing any sign or symptoms of acute decompensation. In case of yes, of course, majority of the times it could be managed remotely by the telephone with adjustment of therapy or assessing the adherence to therapy or whatever. In case the patient reported that he was fine and with reporting any variation in his clinical status, we set to wait 1 week more and programming a new transmission through the Latitude. And what we learned from this preliminary experience about the first step, how to correctly manage the alert, we found out that these alerts are extremely high performing in terms of sensitivity. 100% is a very high number, and this is true both in the post-activation and in the pre-activation, which I remind you was completely blinded. And the lesson we learned is that we could, again, try to use the clinical impact of this algorithm, focusing only on patients which have an alert. So the model that is arising as the winner one is an alert-guided way of monitoring our patient. Secondarily, we had a very low rate of generally of alerts. One alert patient year, both in pre- and post-activation phase, is a very low number. And again, also unexplained alerts were very low. So that means that the hospital workload, which is one of the main issues, which worried all of us coming from previous experience with a previous study. Actually, when we talk about monitoring remotely heart failure patients, the first thing we think is that this will provide us a further work burden. But in our experience, this was not true, because the hospital workload generated is extremely acceptable. And finally, also in terms of anticipation of diagnosis, we can see that we had a significant advantage, because an alert-guided model can provide almost 18 days of advantage before the scheduled transmission and the reviewing. So this is also something that was really important. Okay. And what about the second step, the assessment of the alert? Once we have the alert, we have to assess that this is really telling us that something is wrong in our patient. Actually, we have another important issue, in my opinion, that there are no clinically meaningful conditions or events when we are in an out-of-alert condition. So a very important negative predictive power of this algorithm. So patients that are not in the alert condition, they don't need such intense care from us. We can keep on to follow up, of course, them, but we should focus on patients that are under alert. And again, another important lesson we learned is that the heart sounds where the sensor that was performing better, they were involved in 100% of warnings, and they correlate extremely well with the heart failure acute decompensation. Second, also respiratory trend, increase in night heart rate, and there were other sensors that were very often involved, and thoracic impedance only in 46% of patients. So the lesson is that heart sounds, among all these multi-parameter evaluation, looks like they are the most important sensor that we should follow, especially for their powerful correlation with heart failure decompensation. And what about the way we should act to the event? We know that we had an advantage in terms of 34, 38 in our real-life experience advantage in an early diagnosis, so we can act much earlier than a normal clinical standard of care pattern, and that majority of the another important observation we had is that 25% of alerts were related to discontinuation or reduction of therapy. So HeartLogic can really correlate very well with the lack of adherence to the therapy. And finally, another important issue is that the majority of these alerts were actionable, so we could they were clinically meaningful, and most of these actions were it was possible to give in a remote pattern. So to conclude, of course, now this was just an empiric way to organize our structure, but the answer will come by the MANAGE-HF trial, which is a trial that started 2 years ago. It will be over in 2024, so we need still time. It will enroll almost 3,000 patients. There is a first phase, not randomized, which has the aim to evaluate the clinical integration of HeartLogic for managing patients in heart failure, the same that we did in real life in our preliminary experience. And then there is a most important second phase, randomized, that will compare remote patient management through the HeartLogic alert to drive actions against a model where patients have a remote patient management but without HeartLogic alerts. HeartLogic as a protagonist also in this Congress. That means that it's really a hot topic. There are 4 posters. 2 of them have been selected for the clinical forum session. One is coming from the sub-analysis of multi-sense, correlating, as I told you before, the NT-proBNP values at every hospitalization with the alert, and it looks like that HeartLogic perform equal very similarly to NT-proBNP. Then there is a sub-analysis from the altitude database, which show that progressive worsening in device base at failure sensor measurements are associated with suboptimal LV pacing percentage in biventricular pacing population. And finally, two posters coming from the Italian pilot experience I show you, one correlating the heart logic with the echocardiographic index of systolic and diastolic function, especially the heart sounds sensors, and the second, the one I showed you, the active phase of our preliminary experience using heart logic. So this is just the beginning, as Cecilia told, of a new promising era. The beginning is very encouraging. Still, we have a lot of work to do. We have to learn and to study a lot, but we can, I'm sure that the potentiality of this algorithm will be very important in our clinical practice. Thank you.